Okay, thank you all for coming. We're going to start our symposium now. Dr. Sahil Parikh and I are going to be discussing Supera, showing a couple cases and talking about the advantages of this very unique stent. So I'm Brian DeRobertis. I'm a vascular surgeon in Los Angeles. Started my focus of my training on open surgery, obviously, and that's morphed to largely endovascular therapy, largely because of some of the tools that we now have to treat these more complex lesions that we were typically bypassing. So we're all very familiar with the forces exerted in the SFA. There are a lot of issues in terms of torsion, axial loading and elongation, compression from plaque. These are all things that we've been sort of challenged by as we're trying to determine what the best therapy is for the SFA. The mainstay of therapy for a number of years has been self-expanding NITINOL stents, and these have some advantages, but the truth of the matter is these are cut out of rigid NITINOL tubes, and these stents want to regain and reassume that straight design. The other thing we've been taught is that we need to oversize these stents by 10 to 20%. And I think that is true to get good wall apposition and to allow these stents to help exert the radial force they need to resist compression. The problem is that some of that outward radial force may be contributing to some of the problems we have with our stents. So some of the limitations of standard NITINOL stents are shown here. They have suboptimal resistance to compression. They have limited flexibility because of the fact that they are designed or cut out of these rigid tubes. They can have problems with fractures, and those fractures almost ubiquitously lead to in-stent restenosis or in-stent occlusions. And so we have had some issues with long-term patency because of these sort of factors. The chronic outward radial force that I mentioned already, these are properties of self-expanding NITINOL stents. And you can see from this animal model here, the more oversizing we do, the more in-stent restenosis we get. So this chronic outward radial force is one of the issues involved probably with intimal hyperplasia and restenosis. And that's one of the areas where the Supera stent, which I'm sure most of you are familiar with, really excels. If you compare the Supera stent in terms of its chronic outward radial force to other stents on the market over here, you can see that it has virtually no outward radial force, yet the compression resistance is phenomenal, as those of you who have used this stent already know. This just shows that issue of compression resistance. It has over 4 times the compression resistance of other NITINOL stents that we currently have available to us. And the real evidence of this is after you've implanted these stents and then evaluated them with IVUS, Supera stents tend to have this very round cylindrical shape to them compared to a NITINOL stent that you often will see compression either by IVUS or standard fluoroscopic imaging. So the compression resistance, for those of us who have adopted this as our primary stent, the compression resistance and its flexibility, I think, are some of the key features of this stent. Again, this can be seen on OCT and IVUS, where standard stents are very compressed. Calcium like this is something that a standard NITINOL stent can just cannot live up to the pressure those exert. So the Supera stent's been evaluated in the SUPERB trial, which is its IDE trial, as well as a number of retrospective and prospective registries, and I'm going to share briefly some of those with you. In terms of worldwide data, there are over 1,700 patients who have been analyzed in a number of different analyses, some in, as I mentioned, prospective and retrospective registries. And then the U.S. data from the SUPERB trial consists of 264 patients studied in this IDE trial. This was a study that was done over 34 different sites. It was a prospective, multi-center, single-arm trial looking at stenotic or restenotic lesions. These were all core lab adjudicated results in terms of the primary endpoints of patency and primary safety endpoints. Things to point out with this trial are highlighted down below here in bold. Number one, these patients, or this trial, included about almost 75% or 3/4 of the patients had severe or moderate calcification. So these are things that are typically excluded from other IDE trials of stents, and in this case we had the preponderance of these patients having a severe or moderate calcification. Finally, lesion length is about what you'd see with IDE trials at 7.8 centimeters, probably at the upper limit of standard IDE trials, but certainly we're not talking about particularly long lesions here, and the majority of these within the mid to distal SFA. Looking at the excuse me, looking at the outcome measures here, this Kaplan-Meier curve shows the overall primary patency of the Supera stent at 1 year in the Superb trial at 86.3%. So this, if you think about it, when we think of IDE trials, looking at these SFA stents, this is at the very upper end of the curve, and I'll have another slide that will demonstrate that. We don't have patency rates out to 3 years, but we do have TLR, freedom from TLR rates in the Superb trial. And this was sustained at 83% all the way up to 3 years. So a very high degree of freedom from TLR at 1 year that was really sustained quite well all the way out to 3 years, suggesting a maintenance of that primary patency as well. The other thing to point out is the fracture rate, 0.6% fracture rate at 3 years. In the first year, there were no fractures in the Superb trial. The only one fracture they had discovered out to 3 years was in a patient who had in-stent restenosis with some atherectomy and other procedures to treat that. The real advantage of the stent is seen at maximal, or the maximal patency, or the real advantage of this is seen at nominal deployment. And this is one of the issues with the Supera stent. As we all know, this is not a pin and pull delivery system. It does take a little bit of work in terms of prepping your vessel, adequately pre-dilating the lesion and the entire implanted zone. And then a slow, careful deployment. And this is how all of us who use this routinely will deploy this stent. And the reason for this is shown in this slide. And so this slide shows an analysis that was actually requested of Abbott by the FDA, in which the regulating body wanted to see what would happen to the patency rates of this stent at different levels of elongation or compression. So 86% patency across the entire trial. But what happens if we stretch it out or compress it to some degree? So in those patients who had moderate compression, the results were still pretty good, 80 to 83% primary patency at 1 year. In those patients in whom it was elongated, this is what you really want to avoid, because the benefit of the Supera stent, that patency advantage over all of the other stents we've seen studied in this fashion, really comes at that nominal deployment. If you elongate it, you drop down to about what these other stents show at 1 year, 70, 74% primary patency. Now this was something that the trial operators did not know. During the trial, there were, from what I understand, even cases where they deliberately stretched the stent out to cover more distance, as if it's a variable length stent. And we've found now that the stent really loses its flexibility, and we really want to avoid that. So we do a lot of work now just to make sure that we're adequately deploying the stent after appropriate vessel prep, which generally entails only balloon angioplasty alone with a good non-compliant balloon. And when you do that, when you get that nominal patency, you have a 91% primary patency, which is absolutely unheard of in SFA trials. So that's really where you see the best advantage of this stent, and it really shines above all of the others. When you compare the 12-month primary patency rates for the Supera stent with the other technologies we use in the SFA, you can see that a nominally deployed stent stands out at 91%, which again is higher than just about anything else we see on the market. The Impact SFA trial, the Impact Admiral balloon, has a comparable primary patency at 1 year. Of course, these are much less calcified, much simpler, somewhat simpler lesions. And then when you compare it to Viabon and other self-expanding NITINOL stents, we really see that none of these other modalities meet the bar that the Supera stent meets. And so this primary patency data is one of the reasons that I think people are adopting the stent at an increasing rate. On the other hand, non-stenters like myself, I've always considered myself to be a non-stenter because I use a fair amount of atherectomy and other devices. I was someone who was very opposed to stents in almost all cases. And so the lesions that I really had trouble with or struggled with were the extremely calcified lesions in which I would spend hours crossing a lesion, getting through, and then really I realized I had no devices that could adequately handle the extreme calcified nature of some of these lesions. And so this is where I first tried Supera. And seeing how it stood up to the calcium and all the compressive forces in the SFA, that's what made me a believer in the stent. And then seeing how it held up to longer lesion lengths, again, made me a believer even before I saw this primary patency data, because I realized this was a stent that did things that other stents simply couldn't do, and then was pleasantly surprised by some of the other data analyses that we've seen. This is also from the Superb trial. Again, it points out that if you look at, if you divide the lesions in the Superb trial into terciles, you see that there's no drop in length, no drop in patency across these different lesion lengths. So this is a theme that is reinforced in other retrospective studies, which I'll show you briefly. This just shows a freedom from TLR. I mentioned a very high degree of freedom from TLR at 1 year at 97%, sustained all the way out to 3 years at 94% for those nominally deployed stents. And again, freedom from TLR across the entire trial at 3 years was 83%, I think I said. So very good freedom from TLR rates. This just shows freedom from TLR across some of the other, in relation to some of the other IDE trials for other self-expanding stents. So certainly stands out quite well when nominally deployed, even stands out well if you take all comers in the SUPERB trial. So again, these are some of the recurring themes that really have reinforced the way this is a different stent than anything else that we've used. Finally, this is the issue I already alluded to in terms of why I adopted use of this stent. This shows the primary patency of those patients in the SUPERB trial that were deemed to have severe calcification. And so 77% were moderate to severe calcification. Almost half the patients were considered to have severe calcification. And in those specific patients, the primary patency was 89%, so even higher numerically than the overall subset or the overall trial. And this just shows that in these severe calcium patients, or those with severe calcification, the freedom from TLR again was sustained all the way out to 3 years, 88%, so on par with the overall trial. So it really appears that this stent does not perform unfavorably in these long lesions and in the calcified lesions. This again just highlights the issue of stent fractures. This is because of the flexibility of the stent, because of the ability to resist crushing. The stent is very, very hard to develop fractures in, and as mentioned, only one patient in the SUPERB trial had a stent fracture. This was again past the 1 year time point out to 3 years. So that shows some background on the stent and some of the results from different trials. Sahil and I are going to just go over a couple of case examples that highlight the way in which we use the stent, deploy the stent, and some of the advantages of it. I'm going to show you a case of a 54-year-old woman with right calf claudication. Now this is an interesting case in the sense that she had had a sarcoma resection, which included resection from her thigh, included resection of her femoral artery, and this was replaced with a Dacron graft. And I met her after she had thrombosed her Dacron graft, and I've had to lyse her a couple of times, so I've tried to keep a close eye on her to prevent her from developing recurrent stenosis that would lead to this graft clotting off again. She returned to me once 2 years following her last lysis, or approximately 2 years from her last lysis procedure. She had developed recurrent calf claudication that she hadn't been experiencing with her a couple of years prior. I'll just kind of jump through this really quickly. Her ABI was slightly reduced. Exercise ABIs were reduced even further. Looking at her duplex, she had a high-grade stenosis of the mid to distal SFA within the stented portion of, within the Dacron interposition graft. And here you can see that that lesion right there. So nice large lumen here, nice large lumen here, but there's just a pinpoint of flow between these two lumens, and some organized either thrombus or intimal hyperplastic tissues developed within the distal aspect of this graft. And so clicking through here, this just shows the Command 018 command wire. If you're not familiar with the Command series, I recommend you taking a look at these. These are wires with a stainless steel shaft and a NITINOL tip welded together. Incredible flexibility, incredible torqueability and maneuverability. Good amount of support in the 018 wire, which is a newer wire. It's only been out about a year now compared to the 014 Command, which probably most of you are familiar with. This just shows that the maneuverability of this wire crossing through that lesion, finding its way down into the distal popliteal artery, or the above knee popliteal artery. Once crossing the lesion, we decided to use atherectomy to shave out some of the intimal hyperplastic tissue and organize thrombus here, and had a fairly good result, but not quite what I wanted here. You still see a linear filling defect here, and on IVUS this looked even worse, so we realized we couldn't leave this alone. I had done about as much as I could do with debulking with atherectomy, so decided to go ahead and stent this. And this just shows the technique we use when stenting with Supera. The first step is, what I didn't show you here, I'm going to aggressively balloon this with a balloon that's about 1 millimeter in diameter, half millimeter to 1 millimeter bigger in diameter than my intended Supera stent. And that's really the critical part of deploying a Supera. If you have adequately prepped it with a balloon that is, on average, 1 millimeter size bigger than your stent, the deployment generally goes quite easily. And this shows that deployment here. And this is what you want to see. This appearance is a pretty good deployment over here. Ideally, you want to see a series of black dots on the side, and that means that you're perfectly spaced. Here, you might be able to notice this section there, or over here, it's more like one black line down the side of the stent, and that implies that I'm just a little bit too compressed. So that's not a real problem. What we really want to avoid is elongation, not compression so much, but ideally you want to see that series of little black dots on the side. That means that you've got that right deployment. And then you also want to look at the geometry of the stent, the cell geometry. Really, once you get accustomed to it, it's pretty easy to tell when you're nominally deployed versus elongated or compressed. This shows the completion of that particular area. This is the stented. This is a stented segment down here. It looks quite nice and obviously a good result compared to what it was pre-op. I'm going to try to move through this one somewhat quickly. This is a much more complicated case. This is a patient with all the usual comorbidities who is 93 years old. He had a left silk and toe ulcers, had a prior right AK after a failed fem perineal bypass with cryopreserved vein. Still used this left leg to transfer and preserve some degree of mobility, so this was important to save this other leg for him, as he was still quite functional at 93 years old. Duplex of the leg basically showed a long segment distal SFA occlusion of the distal SFA and the above knee popliteal artery. Had some reconstitution down near the knee joint itself, but even the below knee popliteal artery was fairly diseased. On angiography, had no inflow disease, but patent common femoral and profundus, so we didn't need to do anything there. And the main issue I want to point out here is the degree of calcification. So this is an angiogram, a non-subtracted angiogram. Here, without any contrast, you see the calcification within the vessel. It got much more extensive down to this level over here. So he had multifocal SFA calcific disease, occlusion of the mid to distal SFA with reconstitution at the popliteal level. This shows our attempt to traverse this lesion, and again, you can see all the heavy calcification here. I was able to stay somewhat true luminal with different CTO wires like the Connect 250T and other tools in my armamentarium, down to this area here where I just couldn't penetrate any further, so I pulled out a crosser, and this passed nicely into this area here, but in trying to remove this device, unfortunately, the crosser got stuck and the tip broke off within the lesion. So it just sort of speaks to the degree of calcification and the difficulty crossing all of this. So ultimately, you know, even though I could sort of navigate a wire down to this level, I could not connect this channel here to this reconstitution over here. So this is a good lesion that, or good example of a type of case where retrograde SFA access, as Andre demonstrated just this morning in the forum next door. Direct SFA puncture with a patient in the supine position. You just come in a slightly medial and anterior on the distal thigh. You can do this under fluoroscopic or duplex guidance as long as the patient's leg isn't too large. And it just shows a direct puncture of this calcified SFA passing this row wire retrograde. This allows me to either follow this retrograde wire down with my antegrade wire, or bring this retrograde wire all the way up to the common femoral snare and bring it out to externalize it. So that was done, and this allowed me to bring a catheter down to the reconstituted portion of the popliteal. But you can see even here there's a significant amount of calcification and disease. So I didn't want to land a Supera there. I wanted to get to a healthier portion of the vessel down here. You can see this patient's runoff is primarily this perineal runoff, and we'll show you more of that after we establish our inline flow. So wire access down through the perineal runoff was performed. Treated with this with orbital atherectomy, followed by low-pressure balloon angioplasty. This was my sort of standard for these very calcified lesions where I didn't think I could get a turbohawk or something like that down through. And it did a reasonable result, but you can see residual stenoses over here. There was a dissection here and a dissection here that on the static image you can't appreciate the flow limitation this created, but it was really not an ideal situation. So we went ahead and vessel prepped this with a 5.5 Armada 18 balloon. Inflated this up to 18 to 20 atmospheres, really bringing it up to a little more than the 5.5 diameter. And then anywhere where my balloon did not fully inflate, I'm going to go back with a more focal force balloon, a 6x20 balloon, to really make sure that balloon expands along the entire course of the lesion that I'm going to implant my Supera in. And then this just shows the deployment here. These are static images, but again, the thing to point out are simply that you want to see sort of a series of little dots here. If you have a straight solid line, it's a little too compressed, not a huge problem, but ideally you want to see these little dots along the side and the appropriate cell geometry. And what I do here is I go to full mag, I focus on just the deploying segment. So I position my stent exactly where I want it, then I focus on that distal aspect, and then mag up on that distal aspect and watch that cell geometry. And you can see that even in the face of this heavy calcification here, this stent retains its nice cylindrical shape to it. So this is actually, I believe, my first case with Supera. I did 3 5.5 by 150 Superas from the popliteal artery all the way up to the level of the SFA origin. And again, you can see how this is holding up to the calcium here. Really no compression of the stent all the way up to the origin itself. And then this is the completion image seen here. And you can see that this is a vastly different appearance of the stent than you would expect to see with a nitinol stent placed in this kind of calcified disease. To the point that even my ultrasound techs have asked me what kind of bypass this is, because they're not accustomed to seeing a perfectly cylindrical result on duplex. So I think this kind of case and some of the others that we talk about and you see at these meetings, you know, with its flexibility and ability to go around the knee joint, really speak to the value of the stent in these more complex lesions. So I'm going to stop there and turn it over to Sahil.